Good afternoon and welcome everyone. Thank you so much for joining us for today's Spring into Health event. My name is Haven Spanier and I'm the Senior Director of Programming at the University of South Carolina Alumni Association. And it's my pleasure to get to introduce our host today. But a few reminders before we get started. First off, I'd like to thank Prisma Health for making today's event possible. I also would love to encourage you all to ask your questions throughout today's event. So you don't have the audio or video capabilities because we are on Zoom webinar, but we'd love to have your questions either in the chat or the Q&A. So if you aren't super familiar with Zoom, there's a panel across the bottom of your screen. You can click chat or Q&A, type all of your questions into there, and we'll get to as many of those as we can today. But without further ado, I'd love to welcome our host. Dr. Cedrek McFadden received his medical degree from Temple University School of Medicine in Philadelphia. He completed his residency in general surgery at Greenville Health System and his fellowship in colon and rectal surgery at Georgia Colon and Rectal Surgical Associates. Dr. McFadden is board certified by the American Board of Surgery and the American Board of Colon and Rectal Surgery. So thank you so much, Dr. McFadden, for joining us today. I know we are looking forward to your presentation.
Well, thank you for having me and welcome to everyone and for spending your lunchtime talking about the colon, which is often something people don't do. So thank you for doing that, but very important topic. And so I'm going to share my screen. And if someone could just make sure I'm actually doing this proper. I'm going to make sure.
There you go. We can see it now. If you just
okay, yep. Perfect. So we're talking about colorectal cancer in the very young. I used to do this presentation and I would have this picture up, and it was interesting because I realized that as I gave this talk, I'm an old soul, right? And many of the people on the slide, people didn't know. They didn't recognize who they were. And I started giving this talk and related the commonalities and the history and people who've had colorectal cancer. But I think this is important for this talk because most of the people that you see here are fairly more senior. And they're people that you think, okay, yeah, I could see an older person or an older lady or older male having colon cancer. And so, I mean, everyone from Tammy Faye Baker to Eartha Kitt to Audrey Hepburn to Roddy from The Price is Right announcement. You know, these are people that were diagnosed and died from colorectal cancer. But today's topic is a little bit different because we're talking about the young, and we're talking about people who you're going to see on this screen who perhaps are not the same as the prior screen. They are young, they're vibrant, and in many cases, they're the picture of health. You likely heard about last year's Black Panther star Chadwick Boseman. You may have even heard about Mr. Mancini from the Baltimore Orioles, who you think about health, who else has that health, right? This is a young lady here who lived in Greenville. Her story, she publicized quite broadly. If you ever have a chance, Lindsay Motley was her name, but she was a patient of ours who was diagnosed during her pregnancy. She had surgery, she had chemotherapy during pregnancy, and she fought for several years after she delivered, and ultimately she died. But it's one of the pictures that she did during her campaigning and fighting. And they're actresses, and this young man here in the center here, this is Lawrence Melvin, who's the brother of Today Show host Craig Melvin. He was another sort of younger person more recently that's been kind of publicized, probably because of his relationship to Craig, but also his history of being so young and being diagnosed with colorectal cancer. So let's talk a little bit about the statistics of colorectal cancer. So colorectal cancer, this is the data that's estimated for 2021. Nearly 150,000 people will be diagnosed this year with colorectal cancer. 53,000 or so will die from colorectal cancer this year. And it gets a little bit confusing, but I wrote it this way just so it drive the point home. But it is the third leading cause of cancer deaths when you look at men separately and when you look at women separately. But when you combine men and women together, it is the second most cause of cancer deaths. In South Carolina this year, it's estimated we'll have over 2,500 new cases this year alone, just in South Carolina. If you had to sort of combine all the different types of cancers and those that are most aggressive and those that are not as aggressive, colorectal cancer is probably fares better than many. At 5 years, about 65% of those patients are still alive. And the key with colorectal cancer is the earlier we find this cancer, the better the patient is at surviving. So if we can find it when it's fairly early and localized or in one area, it's about a 90% 5-year survival. But if we're waiting, or we find it when it's more advanced or when it's spread to other areas, that survival is much less. And it drives the point about the importance of early detection and the importance of screening, which we'll talk about today. And I think as we mentioned earlier, if you do have questions, please put them in chat and we'll want to get to them at the very end of the presentation today. Traditionally, colorectal cancer has been a disease of older people. Most diagnosed, above the age of 65 to 74, with the median age at diagnosis around 68. The lifetime risk is in men, 1 in 21, women, 1 in 23. This pattern that you see there means that this is not, and I want to be very careful that this is not a man's disease. That is one of the sort of myths that people will believe. It's a disease of older white men. And we're seeing anything but that, okay? So women, it's, 1 in 23. And so very much important that everybody recognizes anyone can get colorectal cancer. But there are some statistics that bear worth discussing today. In African Americans, they are the highest risk of developing colorectal cancer. Not only the highest risk, but the highest risk of dying from the disease, and when diagnosed are at a higher stage. Several reasons why that's thought to be the case. Certainly we get concerned about the risk factors for colorectal cancer that we'll talk about, and how some of those risk factors have a higher prevalence in African Americans. But it's a little bit broader than just the risk factors. It also includes other factors, such as some of the social determinants of health, of being able to get recommended for the proper screening test, being able to afford the proper screening test, and having the quality care. And there are several determinants that can influence any stage of that, whether it be the ability to get to the doctor or to afford the test, or to have a doctor that's speaking plain English that you can understand, that may go into effect of that. But still some statistics that we really pay a lot of attention to, and we're monitoring very closely and working to correct. Okay? Not everything is bad news when it comes to colorectal cancer. There's been a big push to increase the awareness of screening. The good news is that the incidence has dropped in the US, and we've seen a decrease in the mortality rates. But here's the key: with screening, we could actually avoid, 60% of the deaths that we see from colorectal cancer. The news that we've seen about Black Panther, Star Child, Bozeman, all that does, it raises that awareness, which is so important to recognize, and for people to recognize that it can happen to them as well. So as you get older, the risk of death goes up for colorectal cancer. And again, the older you are, the higher risk of death. But today we're not talking about getting older. We're talking about the colorectal cancer cases in the young, in those that are under the age of 50. So while we have seen an overall decrease in the number of deaths from colorectal cancer over every age, those that are under 50, we've seen an increase in the incidence. The median age for the younger patients is about 44. 3 out of 4 of those diagnosed are in their 40s. And that takes many people by surprise because most people don't think of colorectal cancer as something you're going to get in your 40s or even 30s. The youngest patient that I've taken care of was in her early 20s with colorectal cancer. And so again, it can affect both old and young. Most of the people who are under 50 who have a diagnosis of colorectal cancer, they're diagnosed at more advanced disease. So 60% are diagnosed, they're already at stage 3 and 4 when they're diagnosed, and most of them have symptoms. And the challenge with that is most of the symptoms that they have are perhaps uncaught, or they are not caught, or they are disregarded or ignored. Over 18,000 people will be diagnosed with colorectal cancer under 50 this year. So they're going to be that number that's young. We've seen, as I mentioned before, and this is 5 years worth of data from several years ago that was released, and those that are 65 and older, there was a decrease of 3% per year. By the time we've gotten to 50 to 64 years old, there was an increase of about 1%. Under 50, there was a 2.2% per year increase in the numbers under 50 who've got colorectal cancer. And not just it's the occurrence of the disease, it's the death rate. So that death rate increased by 1.3% in those less than 50 years of age. Okay, so again, something that really is getting a lot of attention. And the big question is, why is this happening? Well, we'll talk about the risk factors of colorectal cancer. And one of those people think about, well, I don't have any family history. But we know that about 30%, 1 out of 3, will have a genetic mutation. If you look at all of the patients, only about 3 to 5% will have a genetic mutation. So there's a big discrepancy there, right? Compared to 12 to 15% of all colorectal cancer patients, there are 15 to 20% under the age of 35 have a family history of colorectal cancer. So we sometimes have patients say, well, I don't have any family history. Well, in this age group, there's a higher likelihood that you have at least a family history of colorectal cancers or polyps. So which is why we're very critical about getting in conversations with the geneticists and talking about testing, not only for you, but also other members of the family, because we want to make sure they are protected as well. So we talked about the genetic risk. There's also pieces about the unhealthy diet link to colorectal cancer in the very young. There's evidence that links having an unhealthy diet to having early onset colorectal cancer. And we're talking about diets that are high in processed meats, fats, diets that don't have a lot of fruit and vegetables in it. That can also be a link to early onset colorectal cancer. And being obese is a risk factor for most cancers. And it may raise the risk of early onset colorectal cancer. Those are cancers that are under the age of 50. In this age group, 50% of patients that are early onset are overweight, and 17% are obese. And there have been studies that have showed that the more TV time and the less activity, the higher that risk of colorectal cancer early onset. And so unhealthy diet can actually play a role in that. It's not just the diet, it's also the bacteria. You perhaps have heard this term, this microbiome. It's the collection of the bacteria in your gut or in your intestines that has certain jobs. And there can be an altered microbiome that can then lead to the growth and spread of colorectal cancer. The toxins are what then leads to that potential higher risk. So the toxins from the bacteria that are normally found, so you normally have this bacteria, but some of these toxins or this imbalance can cause this cancer in the very young. And they've seen this they've seen this in mice. Our bacteria in our guts, it's affected by several things. It's affected by what we eat. It's affected by our environment, what we're breathing, and even what we're drinking. And some things can change the types of bacteria within our intestines. And that includes your diet, that includes the obesity factor, exercise, and even some of the antibiotics can change the types of bacteria in our intestines, which again could be a link to early onset colorectal cancer. Inflammation is thought to be another potential reason why we're seeing advanced cases of colorectal cancer in the very young. We know that gut bacteria, they create or they recruit fighter cells or immune cells that really enable that cancer to develop and to flourish, to grow, and it can block those cells that would normally want to fight cancer. And so this inflammation then leads to chemicals that can change the DNA and can lead to cancer. Now, chronic diseases can cause some inflammation. We know that half of the young adults with colorectal cancer have chronic conditions such as ulcerative colitis and Crohn's disease, and even diabetes that can lead to colorectal cancer. We mentioned earlier the environmental chemicals that are present, whether that's in the pollution in the air and the water, chemicals in the soil, the food, such as pesticide use. What you have to think about is the lifelong environmental exposures that include exposures while in the womb. And if you combine all of that together, if you combine inflammation, the gut microbiome, if you involve the genetic risk and sort of an unhealthy diet, you add all that together, I think you can better understand why we are seeing increasing numbers in people under the age of 50 being diagnosed with colorectal cancer. We don't have a definitive, if you have this, then you're going to get it. But these are the factors that may influence the pattern that we're seeing. And so much research is being developed right now around these four topics, around this cause of how can we better define who is at risk, and perhaps such as we do for, people who have BRCA1 and BRCA2 for breast cancer, perhaps then we do better risk modification. We're saying, fine, we're going to start doing your colonoscopies much sooner because of these risk factors. And so that's kind of where that conversation's going. Let's talk a little bit about the colon. The colon and the rectum constitutes what we call the large bowel or the large intestines. It is a hollow tube. It's about 6 feet long, right? So if you were to take your colon, if you were to take it out of your body and stretch it out, it's about as tall as you are, right? And it connects the small intestines to the anus. And there are 4 layers of the colon. I like this picture here because it puts it in perspective of where the colon is. Imagine like a picture frame around your abdomen. Well, it essentially frames your abdomen, and there's several sides. There's the right side of the colon, I'm pointing there, which is kind of where the appendix tags on at the bottom at the cecum. There's a transverse colon. There's a descending and a sigmoid or shaped like an S-side colon, and then that leads into the rectum here, right? And the main job of this colon really is to act as a storage unit. So when you are having waste after you've eaten and your body's processed it, your colon is basically responsible for holding that and absorbing water, and certainly by the time it gets to the rectum, being able to expel that at a socially appropriate time. And that's really all the colon is responsible to do. You don't really get any absorption of any nutrients from the colon. And that's one of the reasons why you can live without the colon if we had to do a surgical resection of it. There are 4 layers, and this is important when we relate the passage of how these tumors spread and how they grow and become more advanced. So there are certain layers of the colon. The polyps and how these start, it starts on this inner layer we call the mucosa of the bowel. And this abnormal growth leads to a polyp. And this polyp grows. One of the questions people ask often in the office, well, how did I get the polyp? How does it start? Well, essentially, your body has normal stop mechanisms that tell cells to stop growing. If there is a mutation, if there is an error in the cell, the body has normal mechanisms in place to stop that cell from further growing and dividing. And it puts it aside, it kills it off. Well, in cases of cancer, in colorectal cancer, there are mutations in the signals to tell that cell to stop. And so that abnormal cell is allowed to continue to grow and grow and grow and can lead to things like cancer. All right. And not every polyp is the same. There's some polyps that are precancerous that we call adenomatous, and there's some that are not precancerous. All right. But we know that these cancers grow through the wall. It's just a pattern of a picture of kind of what these polyps look like. And there's several different types of polyps. There are polyps that are on stalks, if you can imagine, has a little stem on it, and that may be easier to remove in some cases. And there are also these polyps that are flat. There's no stalk, it's growing right opposed to the abdominal or the mucosa of the colon. And these cancers, they spread primarily through those layers of the abdominal wall. And that indicates what we call the T, or the tumor stage. And the other way it spreads is through the inside of the abdomen. So the colon's next to some other structure. So it may then get it may get in such close contact that it spreads to other organs that it's nearby. It could also spread through the lymph nodes. That refers to the end stage, or through the bloodstream to other organs such as the liver. And if you were to Google staging, the big question always is, well, what stage is it? You're telling me I have cancer, what stage is it? And 3 letters that we determine that stage is by the T, N, and M. The T refers to kind of how far it's grown through the wall. N refers to lymph nodes, how many lymph nodes are involved. And the M refers to whether or not it spread to other parts of the body, such as the liver, such as the lungs. And so these stages are represented here. And as I mentioned earlier, in the very young, we're seeing that more cases of colorectal cancer are diagnosed in advanced stages. So when we see younger patients with colorectal cancer, they're coming in not at stage 1 or certainly stage 0, they're coming in with stage 3 and stage 4 disease. Younger patients are coming in with a more advanced disease. I'll skip this slide here. So really the stage at which it's found dictates the treatment options. If you can imagine, the earlier we can find it, the better we are able to fix the problem, to get rid of it. And so, if it's earlier stage for colon, it's like stage 0, 1, or 2, we're talking about just surgery removal. We're taking that part of the colon out. By the time we get stage 3, we have some lymph nodes that are involved. We're talking about surgery, but also the addition of chemotherapy. In stage 4, likely we get some chemotherapy and maybe surgery, depending on what symptoms are present. For rectal cancer, it's a little bit different based on where the rectum sits in the body. So the rectum sits in the pelvis, and there are more things that are around the pelvis. It sits in a more confined space. As such, when we talk about the treatments for stage 2 and stage 3 for rectal cancer, not only are we adding, potentially chemotherapy for stage 2, we're also adding radiation, so we can try to make that pelvis as sterile as possible, so there's no residual tumor cells potentially able to grow. Stage 4, again, the same as before. But there are several surgical options that we like to do, and this is what we do on a frequent basis. We can remove any part or all of the colon and still be able to have a functional life. And there's several ways in which we do sort of a right side colon resection versus the left side of the colon versus just removing that little sigmoid part. So we're able to do a lot of the surgery in various ways, one of which is done laparoscopically. We take the same surgery we do. It's, there's no differences in the complications, the mortality, the readmissions, or the 5-year survival. And there's a comparable outcome achieved with that of open surgery. We also do a lot of robotic surgery where we do the surgery through smaller incisions as well, but we're able to see sort of a greater depth, sort of a 3D function as we're doing that operation. So that's kind of me sitting at the console here, and one of my partners, he's at the bedside, ensuring that everything's going well. But those are ways in which we can do the surgery, and surgery does not always equate needing to have a colostomy or stool bag at the end of that procedure if we can do it electively. But the bigger question we have to ask, especially for those under 50, is, well, how do we find these cancers? If you're telling me that we're finding them at more advanced stages, well, how am I going to know I have a cancer at all, right? So there are 2 ways in which we find colorectal cancer. One of which is someone's having symptoms, the other which someone's having a screening examination. Let's talk about both of those and get some more clarity on that. What are the symptoms of colorectal cancer? The symptoms include blood in or on the stool. It doesn't matter if it's bright red, dark red. It doesn't matter if you saw it once or you see it every day. Blood in the stool or blood on the tissue is not normal. It's common and it's often blamed on hemorrhoids. Hemorrhoids get blamed for everything, but it's still not normal. And so if you're seeing blood in the stool, on the tissue, in the underpants, you got to talk to your doctor about it to make sure it's not anything serious going on. If there's a change in bowel habits, meaning a change in the frequency, the change in the size, the change in the consistency, or a change in the shape of the stool, those are things that are concerning. If the stool is all of a sudden very thin and narrow, that's a change that may be concerning. If the stool is very hard, small, or rock or pebbles not formed, that may be an issue. If the stool is of a watery or of a mucousy type consistency, that's the problem. Okay. Fatigue can be found in anemia or blood loss. There can be abdominal discomfort, which there's a laundry list of things that can create abdominal discomfort. Not every abdominal pain that you have is from colon cancer, right? But it is on the list of things that you have to be concerned about. And you can see from this picture here that if you have, this is a picture of a colon cancer from a colonoscopy. If you look at this, you can understand why you would have potential symptoms. You're going to have some bleeding because as stool goes by, it's going to create little areas of irritation. It can produce some blockage because you're not going to be able to get the stool to come out because you have a traffic jam. You got this big tumor blocking the path, and you're not going to be able to get the stool out without potentially having some other problems. And so you can see how waiting until it is a little bit larger can create more symptoms. But here's the key point. We don't want you to wait for symptoms, okay? Get a screening colonoscopy. Now, we're gonna say, well, most of the times if you have a younger patient, they may not be eligible to get a screening test. They may be too young for it, right? But if you remember the slide a little bit earlier that we showed, that most of the younger or early onset cancers, they've had some symptoms. I can't tell you the number of patients, female patients especially, that are young, that are diagnosed with colorectal cancer. Many of them will have seen a doctor because they've had bleeding. That's just been because of hemorrhoids. Remember I said hemorrhoids get blamed for everything? So they have this bleeding that is just because of hemorrhoids, and that becomes a common story. So there's perhaps been some symptoms that have just been ignored. Perhaps they brought it up to the doctor, and the doctor said, you're too young, you don't need the test. Here's the point. If I'm treating you for hemorrhoids, and you're still having the same problems that I've been treating you for, I have to make sure there's not another reason for you to be having that problem. So if I'm treating your hemorrhoids and it's 6 weeks later and you're still having the same bleeding, then I have to go in and look to make sure there's not something else causing your problems. Now, it could still be just hemorrhoids, but it's our job to make sure we're not missing something. But in general, especially when you've reached a certain age, we don't want you to wait for these symptoms, get the screening colonoscopy. There's several different ways that we screen for colorectal cancer. The most effective is the colonoscopy, but ultimately we'll take whatever we can get. There's some patients, regardless of how much we ask for it, they're not going to do the colonoscopy. So ultimately, some form of screening is better than no form of screening. Colorectal cancer is one of the few that can be prevented if we find it early enough. I think you remember seeing the picture of that polyp kind of on the stalk or on the stem. If we can find polyps that are that small, we can remove it. It won't have a chance to become cancer. It's really that simple. 90%, more than 90% can be cured if we find it early. And we can actually save over 40,000 lives with surveillance and early treatment. But with all of that being said, 1 out of 3 people, they're not up to date with their colon cancer screenings. So there's some different ways of screening. There's the fecal occult blood testing. There's a flexible sigmoidoscopy, there's a barium enema, there's a virtual colonoscopy, and there's a colonoscopy. And each of these tests has their advantages, their preferences, there are many different options. And this slide is busy. There's a lot of words on it. And so obviously it's going to be way too much to read. But a couple of key points as we kind of move forward from this is ultimately the tests that you see that are not colonoscopy. So if you do a FIT test, you do the Cologuard, which is the mail-in test, you're pooping in the box. If you do any of those tests, if it's positive, it still leads to a colonoscopy, all right? And also the interval or the frequency is different for those tests. We talk about the colonoscopy being perhaps every 10 years if there's no risk factors, and if it's a normal exam. For these other tests, it's going to be more frequent than that. So you're going to be committing yourself to either every year, every 3 to 5 years, if that test is normal. So knowing the differences. And those tests are not designed for people who are at higher risk, people who are having symptoms. It's not an appropriate test. If you're having symptoms, you get a colonoscopy. Okay, and we talked about what those symptoms were: bleeding, change in bowel habits, abdominal pains. Those are symptoms. If you have those, you get a colonoscopy. So any young patient that's having symptoms should not be getting a FIT test. They shouldn't be checking their stool for blood. They shouldn't be doing the Cologuard. They should be getting a colonoscopy. So colonoscopies or screenings start at different times for different people, and it's based on those risk factors. For the average risk, and I changed the slide recently because it used to be 50. It used to be 50 for the average risk patients, but in 2017, the American Cancer Society, they changed recommendations for colorectal cancer screening to begin at 45 years for everybody, because we were seeing the increase in the number of young people being diagnosed with colorectal cancer. All right, so that's as an attempt to try to capture some of those before they get far advanced. We're still missing some, right? Because we're still getting patients that are in their 30s or early 40s. But this is the latest change that which we have. And ultimately, I remind people paying attention for symptoms is the other way at which we can find it. There are also some high-risk people that have some risk factors. Age is certainly a risk factor. The older you are, the higher the risk. If there's a personal history of polyps or cancer, or family history of colorectal cancer, and mom, dad, brother, sister. We're not talking about your great aunt, unless your great aunt was really young, or there are multiple second-degree relatives. That increases that risk even more. Inflammatory bowel disease, Crohn's disease, ulcerative colitis. We've talked about diet and physical activity. All of those increase those risks for colorectal cancer and may influence. If your mom or a first-degree relative, mom, dad, brother, sister, if they were diagnosed with colorectal cancer, you should begin screening or testing 10 years before they were diagnosed. So if your mom was 40 when she was diagnosed with colorectal cancer, you're not going to wait till you're 45. You're going to begin at 30. All right, so that's why it's important to know the family history and to be able to make those adjustments based on those risk factors. Just a few more slides. So the colonoscopy, fairly easy test. It's not as hard as or concerning as many people think. The hardest part for many is just taking the prep the day before. It does require that you just have clear liquids the day before the procedure. You take a bowel prep, a bunch of laxatives to clean the entire colon out so we can see for any abnormalities. The test takes about 30 minutes to do. You are sedated, you get an IV, and we're able to look around the entire colon looking for polyps or any abnormalities that we can try to remove and or biopsy during the procedure. Your privacy is maintained. We're not sharing your photos with anybody, and no one else is invited in the room, okay? So you can kind of rest that you're not gonna be put out on the evening news about your colonoscopy, all right? This is a picture of kind of what these views look like. You can see kind of how clean this particular prep is and how we can look for any abnormalities. This is just different pictures around the colon that we can actually look for any abnormality. And you can see here, there is on number 4, my pointer isn't exactly working here, but on number 4, there is a polyp that will likely be removed during that colonoscopy. A snare, again, this is that polyp on a stalk that we can remove during the procedure if we can find it soon enough. But there are other types of polyps. There's sessile polyps, there's a pedunculated polyp, and this is a mass here that's not going to be able to be removed. It's going to have to be removed with surgery. All right, so let's go through some final thoughts right quick. So overall, let me go back. Overall, the prognosis is dependent on the stage at diagnosis. If we can find these cancers soon, the prognosis is better. But we know that younger patients are diagnosed with more advanced cancers at later stages, which is why we have to pay attention to symptoms. If you have any symptoms, talk with your doctor. If your doctor is ignoring you, not taking them seriously, find a new doctor. Ask for a second opinion. Right? Colorectal cancer can be prevented. Screening begins at the age of 45, or depending on the risk factors or the symptoms, it may be sooner. So if you have symptoms, you're going to have a diagnostic, not a screening. We're going to look for a diagnosis of why you're having that problem, but it's going to start sooner. All right. And the other piece, while we've begun screening earlier, I would also mention that in many cases, there may be some insurance companies that still say, well, we're going to make you wait till you're 50. And in those cases, you need to talk with your doctor to go to bat and say, listen, we think it should be sooner based on the risk of what we're seeing happening. And so, I think you being armed with this information is helpful, but really make sure you hold your doctor and your team accountable to make sure you're getting the testing that you need. All right. With that being said, I've taken enough of your time with speaking. Let's see if there are any questions that are out there. I've also included my email address here, as well as a way to find me on social media. Please feel free to reach out and ask me any questions, but I'm going to stop sharing my screen now, and we'll see if anybody has any questions.
So we do have a question already in the chat. And just as a reminder to everyone, if you have any questions and you aren't familiar with Zoom, there's a panel across the bottom of your screen and you can click chat or Q&A and type in those questions. But the first one is how did you become interested in studying this topic?
Right, so I get that question a lot. I say, well, why in the world would anybody become a butt doctor, right? So I initially went to school thinking I was going to do OBGYN. I wanted to deliver babies. And I discovered during medical school that I did not want to deliver babies. And I did some work with a surgeon in Philadelphia that was phenomenal. He took care of a lot of patients with colorectal cancer, with Crohn's disease. And I was quite impressed and thought I liked the work. There's a lot of variety in what we do. We do a lot of colonoscopies, but we also do some big surgeries and really small surgeries. We do stuff in the office. We take care of all types of patients, not just male, not just female, not just old, not just young. We take care of all types of patients. So that was really appealing to me, just the variety of what I would get to do every day. And so that was one of the big appeals of choosing colorectal surgery. It's a great specialty. People are very relieved when they can poop. And also they're very relieved when you take care of the simple things like hemorrhoids. And it's very rewarding to be able to remove a cancer and to be able to help someone's life be extended. So that I wouldn't trade for anything in the world.
Wow, great. Thank you. This next question is a bit more specific. So this person has a regular 10-year screening colonoscopy on May 17th. They're getting their second Pfizer vaccine on the 4th. Should they move their screening out a week to ensure they're fully vaccinated?
No, you should be fine. We were doing screening colonoscopies through the pandemic, but with much fewer. I mean, we never stopped doing those tests even during the pandemic before we got the vaccine. And so definitely continue down both paths. Get your vaccine, congratulations, and also get the colonoscopy.
Okay, I'm wondering if you could talk a bit more about prevention as far as nutrition goes.
Yeah, so lots of conversation have been had about the role of meat and the fruit and vegetables. And what we find is that there are compounds in meat that lead to more mutations that can lead to changes in the cells that have a chance to become cancer. A lot of the cured meats or processed meats, that's things like, hot dogs, ham, bacon. Those items have certain compounds. It's the nitrates that then lead to mutations in the cell, which is why I advocate having a diet with very little processed meat, having red meat on occasion, if any, and really having a diet that is high in fruit, vegetables, whole grains. So that's, all the good stuff. If you were to pick a diet, I think a plant-based or Mediterranean type diet are one of the better ones to use, because I think it has a way to maintain colon health and making sure that you're having plenty of fiber in the diet. So plenty of the grains will give you that fiber, but you should be getting about 20 to 30 grams of fiber every day. And if that means you add a supplement like Metamucil, you're never too young to start Metamucil, right? So adding a fiber supplement every day will help you get those numbers that you should get for colon health.
Great, thank you. Next question says, how long does it usually take a polyp to become cancerous? I'm on a 5-year plan due to family history.
So generally speaking, colorectal cancer is slow growing. It doesn't happen overnight. It generally takes about 5 years to grow a polyp, and generally another 5 years for that polyp to become cancer. Now, there are some exceptions to that rule. Occasionally, you'll find a very aggressive cancer or a polyp or tumor, but on average, it's a slow growing, which is why we get to that 5-year interval to check for recurrence. But regardless of that time interval, if there are problems, even if you're on the 5-year or the 10-year plan, and on year number 2 or 3, you start having a new problem, it may mean, listen, we're going to abandon that 5 years. We're going to look sooner to make sure we're not missing something.
And I know that you mentioned the time frame was moved up to start getting those at 45 instead of 50. Is that for men and women?
Yes, it's for men and women. And it may be sooner if there's a family history or if there's symptoms.
All right. Well, if anyone has last minute questions, quickly type those into the chat because it does look like we got through all of them. But thank you so much, Dr. McFadden, for joining us today. I know I personally learned so much from your presentation. I'm sure everyone did as well. Very helpful tools that we can all take home and implement. So I appreciate your time, and I appreciate everyone who joined us today. If you all are interested in more of our events with Prisma Health, you can see them at ufscalumni.org/events. There are a few more left in our Spring into Health series. I do have one more question now, Dr. McFadden.
Yes.
This participant says, being that my brother had cancer, should my children start screening early?
So it depends on the age of your brother and if they've done any genetic testing. Okay, let's explain that. If your brother was under 50 when he was diagnosed with colorectal cancer, that certainly increases your risk. And why is he having this cancer? Is there a genetic link? And so that's why many of the younger patients or patients with any cancer, they have genetic testing because they want to make sure there's not any things that's passed along in the family that can lead to that. So the short answer to that question is, if your brother had colorectal cancer, you are obviously every 5 years going to get your testing. And it's going to start 10 years before he was diagnosed or 45, all right? For your children, they're likely going to still be able to start at 45 unless they've had symptoms, or if there are multiple young family members, second-degree relatives, their uncles, cousins, aunts. But because he's a second-degree relative, it makes it less risky for them, but still something to kind of keep in mind moving forward, depending on if there are other family members that get diagnosed. Does that answer your question? If not, I can say it a different way.
That makes sense. That's a good question.
Yeah.
All right. Well, thank you everyone again, and thank you so much, Dr. McFadden. I appreciate your time.
Thank you so much, and thanks for having me.